Good morning, everyone.
Good morning.
How are you all doing today? So, first of all, Stephanie, is this considered the winter or the spring session? It feels like the winter session. Okay, but you never know. So anyway, I'm a pulmonologist. I specialize in pulmonary hypertension, both clinically and at the research level. And I'm tremendously honored to be here. It's a great pleasure, and I would like to thank my partner in crime, Nadira, and Stephanie and the foundation for giving us the opportunity to speak. Sorry, is it better? Isn't your microphone working?
That's the first time I've ever heard anyone say they can't hear you.
Yes, that's interesting, yes. So today I'd like to bring a message of hope and a message of awareness about pulmonary hypertension, which is a disease that I care a lot about. I study it a lot. I take care of a lot of patients. And it's a very difficult disease to treat, as you may know. But I think we have made significant advances in understanding the disease, in figuring out how to screen patients with scleroderma, and we have made significant advances in treatment too. We don't have a cure, but I think we're on our way for it. So I just want to give you an update on what we have. So the first issue with scleroderma is that scleroderma can affect the lung in many ways. And you know, when you have a problem in your lungs, you're short of breath. So there's a bazillion things that can make you short of breath as a patient with scleroderma. And typically, we try to sort of divide in several groups, and Dr. Schraufnagel is going to talk about one. There's, for instance, you know, scleroderma can cause scarring and fibrosis in the lungs. If you have problems with your esophagus, you can aspirate, and that acid can go to your lungs, and that can damage your lungs too. And the area where we're talking about today in my talk is pulmonary hypertension, which is a disease of the blood vessels of the lungs, which is a significant problem. So I don't want to bore you with medical details and things like that, but I want to have one slide here because this is a slide that we go by when we try to understand why people have pulmonary hypertension. Pulmonary hypertension can be due to many things, so we need to figure out exactly what's causing the pulmonary hypertension, and we need to diagnose it properly. The way to diagnose it properly, unfortunately, involves a procedure that is a little bit more invasive than a regular blood work, a regular x-ray, a regular breathing test. But it's a procedure that is safe. It's done multiple times in multiple institutions. It's called a right heart catheterization, where you actually measure the blood pressure inside the arteries of the lungs, and that will give you a diagnosis and an idea of the severity of the pulmonary hypertension. So it's very important that every person with scleroderma who is suspected of having pulmonary hypertension, before this diagnosis is made, this patient undergoes a right heart catheterization to confirm the diagnosis. You should never be treated with medicines for pulmonary hypertension or being told that you have pulmonary hypertension if this test hasn't been done. Okay? So the other problem is pulmonary hypertension is not one diagnosis. It can be due to many different things. Even inside the realm of scleroderma, pulmonary hypertension can be due to different processes. So it's very important that as physicians we recognize this and we study and we do the proper studies on the patients to figure out exactly what's causing the pulmonary hypertension. So for instance, pulmonary hypertension in scleroderma most commonly occurs because there's a problem with the blood vessels that connect the right side of the heart to the lungs. These vessels shrink, they constrict, and they impinge upon blood flow into the lungs, and that causes shortness of breath, and that causes problems in the heart. But pulmonary hypertension can also happen if you have scarring in your lungs. And if you have scarring in your lungs, your oxygen levels drop, and the vessels constrict. That is a response, a natural response of the body to these low oxygen levels. So that's another cause of pulmonary hypertension in patients with scleroderma. And those things manifest themselves differently and should be treated differently. To make matters more complicated, the heart itself, the left side of the heart, can also be involved in scleroderma. And that leads to problems with the heart pumping or with relaxation of the left side of the heart. And all this blood that is on the left side backs up into the right side of the heart and into the lungs. So we need to know, we need to sort of put this puzzle together when we try to understand why patients have pulmonary hypertension and scleroderma in order to make the accurate diagnosis and in order to be able to treat the patients appropriately. Okay? So when we talk about pulmonary arterial hypertension, which is the most significant form of pulmonary hypertension in patients with scleroderma, we're talking of a disease of the blood vessels. And as you all know, scleroderma is a disease that involves the whole body. And it involves particularly the blood vessels of the whole body. If you have Raynaud's disease, if you have Raynaud's phenomenon, you experience that on a daily basis. You see that. You see blood flow being impinged upon your digits. We see the same thing in the lungs. This is not a picture of the lungs, but if I were to take a picture of an artery of the lungs in a patient with pulmonary arterial hypertension, we'll see something similar. These vessels basically go crazy, for lack of a better explanation. They have normally 3 layers. And these layers, they start to grow and grow and grow and grow, and they start to obstruct the lumen, what we call the lumen, which is the center of the vessel where blood flows. And that causes a problem with blood flowing through the lungs. And that's what causes pulmonary hypertension. Problem is, we don't know exactly why that happens. We have good ideas about what that happens, but the way to treat and the way to cure this disease is one day to be able to reverse this remodeling, what to call of these vessels, turn these vessels back into what they used to be. Okay, so this is the crux of the matter, and this is the center of our studies, and this is why patients don't do well when they have the disease. How common is it? It happens a lot in the overall group of pulmonary hypertension. About half of the cases of conditions that are associated with pulmonary hypertension are due to collagen vascular disorders, particularly scleroderma. If you were to break down this yellow chart here of connective tissue disease, scleroderma accounts for the vast majority of pulmonary hypertension associated with collagen vascular diseases. Why is that a problem? That's a problem because that has become the most important cause of morbidity and mortality in our patient population with scleroderma. This is just data looking at what were the causes of death in patients with scleroderma in the 70s versus, late last century and now the 21st century. And as you can see here, renal disease, scleroderma renal crisis was sort of the biggest threat to patients at that time in the 70s. Now we have good treatments for that with ACE inhibitors, and rarely this is a problem. I think Nadira, correct me if I'm wrong, but I think this is not a huge issue anymore. But as this thing starts fading away from clinical relevance, you see here that problems related to the lungs come to the forefront as major causes of problems for the quality and the quantity of life of our patients with scleroderma. How does that translate nowadays in terms of survival? I don't know if you guys are familiar with this. This is called a Kaplan-Meier survival curve. What you see here is these lines are a group of patients, and this here is the survival rate in percent, and here's the years that these patients have been followed from the onset. So if you see that if you have any lung disease or if you have pulmonary hypertension, the lifespan, the quantity and the quality of life of these patients will be shortened. And this is sort of data before we had any available therapies, and I'm happy to report that things are much better. Okay, so don't feel too hopeless. This is the beginning of the talk, not the end of the talk. But this is indeed a problem, and this is a problem that we need to face, we need to be aware of, and we need to attack as fast and as aggressively as we can. Okay, so which are the patients that if you have, and these are not exact things, but which are sort of risk factors of pulmonary hypertension if you were a patient with scleroderma? If you have a disease for a long time, which makes sense. Interestingly enough, if you have limited scleroderma, there seems to be an increased risk when compared to diffuse scleroderma. You guys may be familiar with CREST syndrome, which is the old term. So there seems to be a little bit more risk with these patients but that's not really sort of a huge difference. So everybody with scleroderma, in my view, is at risk. We look for tests in the lungs. So if you have this test called the DLCO, if you have a low DLCO, which measures how much oxygen gets from your lungs into your bloodstream, if those levels are low, that's another risk factor. And your autoantibody profile Don't ask me much about it. Nadira is the pro on this. But if you have a certain antibody profile in your blood, these antibodies seem to confer a higher risk of the development of pulmonary hypertension. What percentage of patients with scleroderma develop pulmonary arterial hypertension? The data is very varied, varies from population to population, varies from which cause of pulmonary hypertension you're talking about. But this is the results of a very good study done in Europe, where they tried to figure out how many patients with scleroderma had pulmonary arterial hypertension, which is that one that involves the blood vessels of the lungs. And after they went to a very rigorous and very regimented screening program in this study in France, they found that about 8% of patients had pulmonary arterial hypertension. So it's not an insubstantial patient population. So it is something that we need to be aware, and it is something that we need to look for. Okay, and it is one of the kinds of pulmonary hypertension. That's one population. Some data suggest that it's even as high as 12 to 15%. Because of that, I think most of the societies that take care of these patients sort of agree upon a need for screening these patients. So we are firm believers that pulmonary hypertension needs to be screened in patients with scleroderma. So all patients with scleroderma should be screened. All patients who have a suggestion based on the non-invasive screen for scleroderma should have a right heart catheterization. And a right heart catheterization is mandatory for the diagnosis. So what tests do we do? And what can we do to try and diagnose this non-invasively? So there's a lot of controversy. There's a lot of new studies coming around. And I think things are going to change a little bit, but this is sort of the kind of a consensus right now, is that patients need to have pulmonary function tests. That serves two purposes. It looks for scarring in the lungs, and it helps look for pulmonary hypertension. They need to have an echocardiogram, which is not a perfect test, should never be used to diagnose pulmonary hypertension, but is a test that will help you sort of stratify and look for pulmonary hypertension, because there are some signs on the echocardiogram that suggest the presence of pulmonary hypertension. I particularly like measuring this blood test too, which is a hormone that's secreted by the heart when the heart is under stress. It's stretched, the muscles of the heart get stretched, and that happens with pulmonary hypertension. And that when that level is high, that's also suggestive. And then there's this algorithms that we put sort of the DETECT score, which is coming out, it's just been published. It's sort of a numeric score that you sort of combine all these parameters, and you sort of have a risk assessment, and that will sort of give you a relative risk of having pulmonary hypertension, and that should guide you towards, doing more invasive tests. So I'm a firm believer that we should do this every year on patients with scleroderma. In some patients where I see borderline results, where I'm more worried, I do it every 6 months until I see their stability or not. And anytime a patient has a symptom, which is more commonly shortness of breath when you have pulmonary hypertension, even if I don't have classic signs of pulmonary hypertension on my studies, but I cannot find an explanation for the shortness of breath, I would consider a right heart catheterization. So that has to be in the back of your minds too. Now, why is that important? Why do we screen? Does it matter? Do I just give you more anxiety by knowing that you have pulmonary hypertension and there's nothing to do? No, the answer is no. The answer is there are things we can do that will probably help you feel better and live longer if we attack this early. One of the greatest problems we have in pulmonary hypertension, in general, and particularly in patients with collagen vascular disorders, and the majority of these patients will be scleroderma, is that we diagnose patients late. So these, I'm not sure how familiar you are with this, but these are functional classes, go from 1 to 4 in terms of how short of breath you are when you walk, when you exercise. From 1 is you're not short of breath at all, to 4 you can be sitting there and be short of breath. So that, of course, you want to diagnose patients early when they have very few symptoms, because that tells me that the disease is not advanced. Unfortunately, the majority of patients we diagnose with pulmonary hypertension, and this is data from a large a cohort study that look at patients with pulmonary hypertension, and let's focus here on the patients with collagen vascular disorders. Most of the patients are diagnosed in functional class 3, which is pretty advanced. So the idea is that if you screen patients, you may catch the disease earlier, where you can treat more aggressively, and hopefully patients will do better. So is there any evidence that this happens? And this is not perfect data, but this is data from a cohort study, again in France, looking at patients who were diagnosed with routine clinical practice when they showed up with symptoms, and a smaller number of patients who were diagnosed with screening. And as you can see here, screening led to an earlier diagnosis in terms of functional class. So patients were picked up when the disease was less advanced, which is a good thing. How does that translate into sort of, clinical hard parameters that we use to define severity of the disease? It shows up well. So this is just measurements of pulmonary pressures and measurements of pressures in your heart and in your lungs when you have a catheterization of the heart. So this is the mean pulmonary artery pressure. So this pressure has to be less than 20. More than 25 is a diagnosis of pulmonary hypertension. So here in patients with routine practice, the pressures were almost in the 50s, which is very, very high. In patients who underwent a detection, early detection scheme, the pressure was lower. So the disease was diagnosed, in fact, and conclusively at a earlier stage when the disease was less severe. Good thing about it, and this is not a randomized study, this is not a clinical trial, this is just patients being observed over time. But as you can see here, the prognosis of these patients was better. They did better. Could this be that we're just diagnosing it late and we're earlier when we're following them for a less period of times? It's possible. But I mean, these guys were relatively comparable in the duration of their disease. And these patients did better if you detect them earlier, likely because patients were treated more aggressively earlier. So I think that's one of the most important messages I could leave you with, is that we need to be aware of this, and we need to tackle it, and we need to try and find it as early as we can. How about treatment? I'm not going to talk forever about this. I'm just going to tell you that, last century, back in the 90s, in 1990, if you have pulmonary hypertension, pulmonary arterial hypertension of any form, you had a pretty dismal prognosis. Most patients would die within 2 years. Okay? There were no FDA-approved drugs. First drug approved for pulmonary hypertension was approved in 1996, if my memory serves me right. So those are the prostacyclin drugs. So those are based on some science looking at pathways in the lungs that are abnormal in patients with pulmonary hypertension. Basically, what you see is there a lack of substances that vasodilate the lungs, that make the vessels expand and makes the vessels thin without all this remodeling. So we know that this molecule called nitric oxide and this molecule called prostacyclins are low in patients with Scleroderma-related pulmonary hypertension. And we know this guy endothelin, which is a very potent vasoconstrictor, so it does the opposite. It constricts vessels and make them proliferate, is high in patients with pulmonary hypertension. So studies have been done. We started with cells, then we went to mice, and then we went to patients, the usual route. And drugs were tested and approved. The first group of drugs were the prostacyclins, which are the big guns, and you guys probably heard of Flolan, Remodulin, and the ones that are very potent and very cumbersome to use. But those were the first approved class of drugs. Then, not in chronological order here, the endothelin antagonists came aboard. So those were the first medicine that you could take as a pill. So made it incredibly easier for the patients. Now we have 3 classes of these drugs that are available. And then the phosphodiesterase 5 inhibitors, Viagras of the world, and this new drug, Riociguat. So here you see the cadre of FDA-approved drugs that are now available in the market. So we went in a relatively short period of time from nothing to a lot. So there are drugs, there are therapies available, and patients respond to the therapy. We haven't cured the disease, but patients respond to the therapy. Good thing about it too is that these drugs affect different pathways. So at least at theoretical level, and now with some more evidence at a practical level, data from clinical studies in patients, these drugs help each other when they're used in combination. So it's like treating high blood pressure. It's like treating HIV. It's like treating cancer. You know, we try to attack this from multiple angles. So there's a lot of data suggesting that combining some of these drugs may give you an extra boost and may help the patients. So, you know, very rarely you have a patient with scleroderma and pulmonary hypertension that one drug and, yeah, didn't get better, that's it. No. There's things you can do. You can add drugs. So there's also more variety of therapies that we can use that are available for us. Now, I want you to memorize this. This is going to be a post-test after my talk. Now, this is just a slide that I put in just for you guys to have an idea. This is sort of a schema of a cell, and this is a blood vessel. This is the abnormal blood vessel in patients with pulmonary hypertension. And these are some of the pathways. These are the things that scientists are looking for as far as potential targets for therapy. So it's not only restricted now to these three sort of pathways. We're learning more and more about different things that could be attacked. Okay, so unfortunately, this is mostly at lab level and at sort of the empiric level, at the animal model level. And I'm happy to say, if I was a mouse or a rat doctor, I have PH cured in 1 second. I've cured PH in the lab several times, and unfortunately, we haven't made it to some of these things have not made it to the clinic, but hopefully they will. And so what is sort of the current thinking now in terms of what to do and how to attack this disease? So as I mentioned to you, the normal vessel is very thin. It doesn't have, much in the way of skin, so to speak, or meat, so to speak, blocking the lumen. So you see the blood flows freely in here, okay? What happens in PH is that you see these vessels go crazy. All the walls start to grow and grow, almost in a cancer-like fashion. And they block blood flow. And that's where the problem is. And nowadays, so we're studying a lot what to do, not just to cause the blood vessels to dilate, but cause these things to go back to where they need to be. So these are several different sort of, mechanisms and areas. So we're almost thinking like we need to treat this like cancer. And a lot of the drugs that are being used now have been used in patients with cancer. Like, they're now available orally. So a lot of the studies are going towards these directions. And then, there's a lot of inflammation in these areas, particularly in patients with scleroderma. So things that block inflammatory pathways. Attacking gene regulation and how these genes are regulated. Some genes are turned on, some genes are turned off. So ways of turning on and off these genes the right way. And then this is interesting too, progenitor cells, stem cells. I wanna give you a word of caution about this because there's two sides to this coin. There are serious studies looking at this. There's particularly in Canada, a physician by the name of Duncan Stewart is studying that. But if you see 60 Minutes or if you do a little bit of web-based stuff, you see a lot of crooks around there. I don't know if you've seen this guy who was promising stem cell therapy and taking stem cells from weird places and flying patients to Central or South America and infusing them with these drugs for a pretty penny. So, there are things that you are going to see that people are promising this stem cell therapies on the web. And I want you to be aware that these things have not been proven, have not been sanctioned by any governing bodies such as the FDA or the European regulatory agencies. So if you hear the word, if you see that on a website, and if it's not in the context of a clinical trial, run, okay? Do your 6-minute walk test away from it, okay? So don't get involved with this because those things are potentially dangerous, and if anything, they won't do anything, and they will cause you distress and a lot of money. Okay, so those are things that are available and are becoming hopefully available. Finally, lung transplant is an option for patients with scleroderma. Okay, it is difficult because it is a systemic disease. So finding patients at their best for the lung transplant is hard. You need to make sure that your body weight is okay. You need to make sure that The rest of your body could take the transplant. But in selected patients, in patients who are good candidates, patients with scleroderma do as well as patients, let's say, with pulmonary fibrosis, which is another very common cause of patients needing a lung transplant. So those are options that are available, okay? So we don't have a cure. Hopefully we will have a cure one day. We need to be aware of the disease. We need to reassess. We need to follow patients carefully. We need to be aggressive about trying to treat and maximize the therapeutic options. And escalate the level of care. Be connected with a team of experts in the area, because this is not easy. I mean, pills, okay, but when you start flow and infusions and things like that, it gets complicated. It's involved, and you need a lot of support. So to finish it off, I think I hope I conveyed these sort of points to you, that 1 in 8 of patients with scleroderma develop PAH, that detecting it early will probably have a favorable impact on prognosis, that we have a lot of potential therapies that are available right now. They work. They do not work on 100% of the patients. Not all patients respond well, but a lot of patients respond and do better. I think sort of the standard of care is, if patient doesn't respond to one drug, is to add therapies. There's a lot of clinical trials that are ongoing with this, so this is another plug that I think patients should think about participating in these clinical trials for drugs and for studying the genetics and studying different things like we do in the lab. And then we continue to study and look for new targets, and the hope is that one day we'll come up with a cure and I don't have to come and talk to you about this, but we're not there yet. So thank you very much, and I'll be happy to answer any questions.